If I can have everyone's attention, we're going to give ourselves a little bit of a head start so that we stay on time. Welcome everybody back in for our next presentation. But before we do, I want to make a plug for something called the Rare Epilepsy Network. By a show of hands, if you've heard the acronym or that and you know what it is, raise your hand. Oh, I'm so glad to see so many hands. If somebody sitting near you doesn't raise their hand and they don't know, please take the time to explain it to them, just so you know. The Rare Epilepsy Network is a registry that was founded by and for the rare epilepsies. It's been in existence now for about 3 years. Hope for HH, and HH is a big part of it. We've registered over 80 patients and their caregivers. And so many of the questions that we all care deeply about, the emotional, the psychological, the sleep, all the things that all of our individual journeys have shown out, that information is collected as a part of this registry, and then it is made available to researchers around the world who will look for the patterns and try to help figure out the puzzles. So I can encourage those of you, especially those of you that are newer to diagnosis, if you would like more information, there's a brochure in each of your bags. If you want hand-holding to get it done, I'm your girl. Call me. See me while you're here. See me afterwards, and I'm happy to help walk you through it. But we're trying to get every family that's touched by HH to participate in this incredibly important resource so that we can get the information that we all desperately want, the answers to the information that we want. With that, speaking of research, I just want to let you know that, as many of you know, the foundation offers support and information, and that's a big part of our mission, is to make sure that when families are newly diagnosed, suspect an HH, or even have been living with it for many years but are experiencing maybe new things along the journey, that there is a reliable and reputable source for them to go to. And we take great pride in working with the medical community to make sure that we're maintaining our information to the highest of standards. Another big part of our program is funding research, and it pleases me to be able to share with you that this year we funded 3 grants, 3 projects essentially, that we hope will do what Dr. Kerrigan started to allay to, which is begin to translate things that they're studying and learning about in the laboratory and make it of practical application to our families. And we take great pride in being able to be joined today by Dr. Varina Boerwinkle and also her colleague, Sam Teresi, who are working on a project that involves fMRI. I'm not going to even attempt to summarize. I will turn it over to Dr. Boerwinkle for that. We're delighted to have her.
Hello, everyone. Thank you for having me. And if it sounds like I have pressured speech to the psychiatry folks in the room, it's because I'm opening a fire hydrant here of information and trying to give you as complete a picture as possible of the research that's been going on in regards to HH and epilepsy and resting state functional MRI, and summarize all of that for you in probably what should be an hour-and-a-half talk in 20 minutes. So here we go. My disclosures are that the Hopeful Hypothalamic Hamartoma Grant did fund the project for which I will be presenting for the first time the results towards the end of this presentation, and in conjunction with the Aloe family. So thank you very much. Oh, I should say, thanks for allowing me to be your reporter at AES, and here's me in the press room enjoying my press privileges. Here's the team that I've been working with on the projects for resting state functional MRI in the hopes of reducing seizures and stopping seizures using this tool in conjunction with surgery. Too many folks to introduce here, but thank you so much to the team, and especially Sam in the room. So what is the challenge? If you're looking at the picture here on the left, this is a child who had a laser ablation surgery of his hypothalamic hamartoma and did not change the seizure frequency post-operatively. And yet another laser ablation surgery done here sometime later and still no change in the seizures. So why is that, and what can we do to improve our surgical outcomes? So in this child who had a resting state functional MRI done after that second surgery, we could see that here that the seizures were actually coming from the opposite side of the hamartoma and flaring out over the opposite side of the brain from where the seizures were coming from. And so the team at the time was misled by this asymmetric abnormality that was fanning up on this side of the brain that was seen on the surface EEG, and so they logically went for that side of the hamartoma, which was actually more highly connected to the brain than the side where the seizures was coming from. And so this child received a laser ablation of this area and then became seizure-free. So what is functional MRI? Most folks know what functional MRI is based on task-based MRI, where a person is in a regular MRI scanner and they perform a task. They have to cooperate. They need to be awake in general. And so this is just an example of someone opening and closing their eyes and looking at that, what's called bold signal, coming from the visual part of the brain. And you can see where it gets stimulated. And we basically have to just simple subtraction of this signal between the on and off periods to determine where in the brain that signal is localized to. But what about resting state functional MRI, where someone is just resting or lightly sedated, not really performing anything at all? Can we see where all the brain networks are using this type of a paradigm? And in fact, we can. So this has been known for about 20 years now, that we can take this bold signal and decompose it into all of the major brain networks. So this is an example of a patient of ours who we decomposed each signal from each network of the brain, and we can see all of the major brain networks. And so this is true also for children who have epilepsy. Most of their brain networks are still intact, and we can look at all of their brain networks. But what can we see about where seizures come from? Could it be helpful with that, looking at abnormal signals as well as normal signals? And in fact, we can. So this is my first paper, just trying to get at, separating out the abnormal signals from the normal signals. First, we need to understand if the abnormal signals come from the hypothalamic hamartoma, where do they go to first and where do they go to next? And so this was the first study of its kind showing that you could use a functional MRI to get at seizure propagation patterns through the brain to understand this. Oh, I'm sorry. Actually, this is actually the second paper I put out, and this looks at all of epilepsy in general. Can we localize the signals that show where the seizures come from? And really what's interesting about this paper is even in children who don't have a lesion on the MRI, so this is cryptogenic localization-related epilepsy, we were able to see where their seizures come from in the brain, as well as the children who had seizures from a lesion. And so what we ended up figuring out is if we put the signals that come out of the MRI machine, so all of those network signals, and put them through the same sorting paradigm into which one are they are, like a noise signal or a real resting state network, or is it a seizure-like network or something that I don't understand, it's something new. And so sorting all those signals, and each child has approximately 100 signals that come out of their resting state functional MRI and need to be sorted in this fashion. So this is from the first about 350 patients that I studied. Currently, I've probably studied well over 1,000 different resting state functional MRIs of children with an intractable epilepsy. And so this paradigm was developed off of the first 350 and then applied to the next 40 going to surgery. And we were able to see that when we put electrode depths into the brain to verify, or strips onto the brain surface, were seizures coming from the exact same place that the resting state functional MRI said that they were coming from, and in fact they were 90% of the time. So that level of agreement was statistically significant, or highly statistically significant, and it included children who had lesions and did not have lesions. And so this publication came out this last September. So that's the agreement rate between the cryptogenic and the symptomatic was 90% there that you see. And so we went through and looked at children who then went on to surgery to understand what is the sensitivity and specificity of this test. And this is one of these types of charts that helps us get at that, and looking at Engel classification, which is understanding like how many seizures you're having post-operatively. So Engel class 1 is good. Engel class 2 through 4 means you're still having seizures. And as you can see, most of the time the neurosurgeon was able to resect the area that the resting state said that the seizures were coming from, and they were seizure-free post-operatively. So looking at the rest of these categories, what does that mean for sensitivity and specificity? So I just kind of went through and defined what true positives, true negatives, and false positives, and so on and so forth to get it calculating out that value. And so the sensitivity, which means if you have this test done, what is the likelihood that we will be able to identify your seizure source anywhere in the brain that it's coming from, anywhere? And if you have more than one, will we identify both of them? So the sensitivity was 93% in this patient cohort, which was all comers to the epilepsy surgery suite of Texas Children's Hospital over a 3-year period. And the specificity by this kind of like, I couldn't actually calculate specificity because we didn't have any true negatives, but as like a surrogate marker of that, it was about 78%. So that means that if I identified an abnormality, that it in fact was a seizure source, versus, say, something else, like a downstream area of network dysregulation. So this is actually fairly high for a test. So it's comparable to, say, MEG, or magnetoencephalography, which is considered a highly sensitive and specific test. It's sort of like the fanciest EEG on the face of the earth. So these are just some patients that were in that cohort, and just looking at what does a seizure source look like on the bold signal. So I showed you what looked smooth and undulating, which is a normal network. The bold signal out of a seizure source is fast and erratic, and it has a higher spread of its power spectrum. So it definitely doesn't look normal, and you can figure it out if you have some experience looking at this population. So I put up some other examples, but I won't go through them here. But these children were part of this study, and some children had 2 sources. One of them was removed, and then the other one was not, and they still had seizures that looked like it came from that area still by the semiology of the seizures. Okay, now back to HH. So this was the study actually where I was looking at initial areas of seizure propagation. So using a resting state to get at what normally you would use depth electrodes. So if you have one area of the brain that fires off a seizure, where does it go to next and next and next? So if it's somewhere deep in the brain like the HH, the first place we're going to detect it is somewhere on the surface of the brain, which the surface EEG is only detecting like the last couple of millimeters out here. So by the time it gets up here, it's obviously mislocalized in an HH case, for the most part. Can we use resting state to help us figure out where seizures go, where they start and where they come from? So this was in 12 patients who had an HH and in 6 controls. First, we detected all of their normal brain networks between the controls and the children with HH. And then we determined what were the differences in all of their major brain networks between those 2 groups, the controls and the HH group. So these were all the differences in the networks. And then we said, well, what has that got to do with the hypothalamus? So we then went on to a further calculation that looked at what is the connectivity between all of these areas of difference and the hypothalamus itself. And we came down to these areas then that are the most disrupted. And looking at their p-values of their connectivity, so that's just kind of like demonstrating what we did. What do all these areas have to do with the HH? So all the areas with the lowest p-value, so that means most statistically significant, were the areas found by completely separate modalities of study to be the initial areas of seizure propagation. So, for example, children who had depth electrodes placed or concurrent EEG with fMRI, these were the same areas that those other modalities, multiple modalities, said that these areas were the first areas that the seizure propagated out of the HH, as compared to downstream areas which were found to be not statistically significant. So when I first started studying children with HH, I didn't have an analysis paradigm special to them and was just using my regular filtering paradigm and looking at these signal sources, which were obviously abnormal. It didn't look like normal resting state functional MRI networks, knowing they had an HH, but how then can I provide information to the surgeon that would be clinically actionable? So we needed another step to help us get from point A to point B, because this wasn't going to be good enough. So the next step was to use all of that information that was provided by the first step that all the other children received, filtering out noise from normal signals and then what looked like abnormal signals. So getting all the noise out of the signal, which was the first step, then moving on to what I call Searchlight, in which we look at every single voxel, which is like everywhere I can place this little red dot through an going through the entire HH, click by click, where in the HH are these seizures coming from? And to understand that, after taking out all the noise, I calculated the connectivity between each place within the HH and the entire rest of the brain. So in this child, where the red dot is there, you might not be able to see it from where you're sitting, it had this pattern of connectivity to the rest of the brain, which corresponds to the same areas that on our first study we could see that these are where seizures propagate to first out of the HH. So that this made clinical sense that this probably was where the seizures were coming from and was clinically actionable, that we should aim our laser or whatever modality we want to use to destroy that area of the HH to end the child's seizures. So how did it go? So 1 week postoperatively, this is now the connectivity pattern out of that HH, which is far more quiescent, and this is just noise pattern over here. And the child was seizure-free. And then 6 months later, still all we had was just residual noise pattern, no connectivity between that area of the HH and the rest of the brain. So this child remains seizure-free. So that was just one child. So how do we figure out this is really working? So we need to do a group level analysis and look at lots of children to understand if this is really going to pan out or not. So what we did to figure that out, thank you so much, Sam, is we took all the children's preoperative image, and this is one individual, okay? But we did this for all of the children, and there were 51 in total, children who were enrolled in this study. And so we said, okay, here's their preoperative imaging with that analysis that I just described to you. Then during the operation, we collected 2 types of images to let us know where the laser was lesioning the brain. And so these 2 types, this is an FFE and this is an ISO diffusion weighted study. And so you might be able to see that there's like a little area of whiteness here, and then on this gadolinium enhanced image, sometimes the contrast would leak out of the blood vessels as we would expect it to where a lesion is being created. So we weren't sure which type of image would let us know interoperatively if we were lesioning the brain where we thought we should be. And so both types of images were collected interoperatively. And then postoperatively, about 6 months to a year later, another MRI was done. So what we did was we took that same analysis, the preoperative analysis, where that point was where I said this is where we should laser, and then overlaid it, the exact same analysis, this is the same picture, overlaid it on each one of these 3 images here, which sounds easy, but actually is highly technically difficult to do with registration differences and automation. And so this actually took the help of Sam Torsey from the NIH to help program this for me to be able to automate this. And in the process of doing so has really opened up this tool for analysis of any part of the brain for all children of any type of epilepsy to be able to query their brain on an automated basis using any type of imagery. Thanks to the HH program for funding that. Okay, so this is one child, and so after I moved from Texas Children to Phoenix Children's, I had the accessibility of a bioengineer who then put all those points that we were just looking at that automated over the HH and grading it, whether or not it was ablated or not, using the intraoperative and postoperative imaging to understand if, in fact, we had lasered the targets or not. So each child's HH points were put into a newly created computer program just for this purpose that Stephen Folds did for us. And so you can look at this child's points, and all the black areas and anything circled in black was ablated, and anything not circled in black was not ablated. And this child still had some residual seizures and had these 2 missed targets that you see here. Then the child went on for a second ablation, and all of the targets were ablated the second time and had no further seizures at 1 year postoperatively. Okay, so was this statistically significant? So we had 15 controls and 36 children who received resting state functional MRI with high enough quality to be included in the study, and that's a total of 51 children. And so you can see these are all just sort of their preoperative aspects about each child. Some of them that I might point out are, what size is that HH? We talk about surgical complexity. Children who have large or massive HHs in general, the data shows that it seems like they may require reoperation, and some of that is due to safety issues or limitations of the technology. So a surgery trajectory of a laser is linear. It's not curvilinear, and so we can ablate something in a straight line. We can put in multiple trajectories, but every time we put in a new trajectory, that is increased risk to that child during the surgery, potentially. And so sometimes these are done in a planned stage approach intentionally. So that's in regards to surgical complexity. And if we can look at the size of the HH mean, the children in the RH, the resting state group in general, were our more complex cases, and at times, sometimes the easier, if you will, or smaller HH went to the control group. And so I'm just going to mention that here, but it wasn't statistically significant, but it approached statistical significance. So less than 0.05, and the p-value is statistically significant. But so there was some difference, but it didn't meet that criterion. And then, so here's percent seizure improvement postoperatively. So there's a 51% improvement in seizures in the control group and an 84% in the resting state, and this was statistically significant. We tried to control for the size of the HH and also the degree of severity of preoperative seizures, so we adjusted that to see if that made a difference in our results, and not really. So this is the adjusted difference in seizure outcome between the resting state in blue and the controls in red, and this is the adjusted, and it was more or less the same. So this is just reiterating approximately 35 to 39% improvement between the adjusted and the unadjusted groups in their seizure improvement, and both were statistically significant. So it's about 40% improvement using resting state as the targeting modality. Okay, so let's look at other outcome parameters. So how about children who didn't improve at all? In the resting state group, nobody did not improve. In the control group, about 33% did not improve after surgery. That was statistically significant. How about children that improved at least 90%? In the resting state group, we had 24 children, or 66%, who improved at least 90%. And in the control group, we had 6 children, or about 40%, who improved at least 90%, but this did not reach statistical significance. Approached, but not reached. Okay, how about cured? So 6 children in the control group were cured. In the resting state group, 20 were cured. Cured as in like not even having gelastic seizures. So this might be a little bit different than some papers out there consider cured if you're having anything, all your other seizure types were gone, but you still have gelastics, and they might consider that a cure. So this should be looked at carefully when comparing papers between cure rates. This just went right over statistical significance, so 0.05. So this definitely approached it. Probably one more patient in the study, we'd have been there for cure rate difference, but that's pretty darn close. Okay, so where are we going next? So we have the ability now to understand using resting state that we can use this as a fairly reliable tool based on this study to know where to target HHs for ablation. But what can we do intraoperatively to improve so that the child doesn't have to keep going back for surgeries or leave that surgery still with seizures? Can we do anything about that? And so that's my next, I can't even believe I'm saying this, ambitious plan over the next phase to bring that live to you, where we, inside the operating room, take a resting state functional MRI, ablate where we need to, take another resting state in the operating room, give further direction, and then have the child seizure-free before they leave the OR. So in summary, we have about 33% better seizure control using resting state to understand where to lesion the HH. Cure rate that didn't meet just gray statistical significance, about 29% increase in cure rate, if you will. A 33% reduction in the no improvement bracket. There were 0 non-improvers in the resting state group, and 26% increased 90% improvement bracket that didn't meet statistical significance. So why should we try this plan of doing it inside the OR? We get immediate surgical direction, will potentially increase our cure rate, decrease need for repeat surgery, and something I haven't mentioned yet, what about safety? So as Nicole mentioned, her daughter had a mammillary body destroyed during surgery. Mammillary bodies are absolutely critical for laying down new memories. If we destroy 2 mammillary bodies, that child will never learn anything ever again through traditional memory circuits, and is extremely dangerous. And so blinded approaches at surgical ablation are suboptimal. So the less blinded we are when that child goes in, the better off we are. So we can use resting state potentially to query the mammillary bodies intraoperatively to ensure that they are not heating up or decreasing in their connectivity pattern. So this could potentially lead to more aggressive surgical approaches because safety margin could be higher with this approach and potentially increasing cure rate. So another reason why we might consider this. I think I wanted to say a few words about children who still have gelastic surgeries after surgery. It seems like there's a trend that after surgery, many children still have gelastic seizures. And looking at the broader question of this forum, what about executive functioning, and what about psychiatric emotional control differences in children, and what can we use resting state for in regards to that? And so here we go. I think that resting state functional MRI can answer a lot of these questions for you. My very first HH forum that I went to, I sat down with a bunch of moms to eat some fish tacos, and they each talked to me about their particular child. And I was hearing, similarities and differences between each child's story. And then we got to the last mom who said that her child died and wasn't here to tell more about her child's story and how her child's developing. And I was really struck by that and obviously couldn't finish my fish tacos. And ever since then, I've really felt a great urgency to try to hurry up and get answers for you all, and especially in memory of her daughter. And so since then, I've really been highly focused on stopping seizures. And Jack has urged me over time to really think about the bigger issues of the encephalopathy, namely the emotional and executive functioning issues, which you guys deal with every day. And according to what we're hearing from the AES forum, actually contribute to quality of life measures, perhaps even more than seizures. And so any intervention, could it be a medicine or a behavioral intervention? If we were to be gathering resting state function MRIs, on a serial basis, as Nicole's daughter receives neuropsychiatric testing on a serial basis, we could look back over a plethora of children from anywhere in the world that there is a MRI machine and aggregate that data based on what intervention those children are having and looking before and after and kind of put this whole thing into hyperdrive. But looking at one intervention, you know, in say all 2-year-olds who received ABA therapy with an HH that was small and ablated and this, you know, and like how fast are we really going to make progress with that? And so I'm kind of putting out to the community that the tools that I've created are now freely available as they were funded by you all. And that we might be able to really get a handle on this a lot quicker. Now, what could that mean in the bigger sense? So we know that folks who have other disorders such as Alzheimer's or bipolar or severe rage attacks benefit from lesions put into the brain at very strategic locations, and they can function much better afterwards. Other interventions such as deep brain stimulator, such as to the amygdala or other areas seem to modulate behavior, and psychiatric types of interventions using deep brain stimulator. Could our children be candidates for this who are not amenable to medications or don't seem to be making very good progress with behavioral interventions? So you brought up your child's sleep disorder. This sleep disorder sounds pretty severe. Your child doesn't sleep at night very much. Could that have to do with the hypothalamus or a brain network really unrelated to mood and is probably due to the network out of the hypothalamus? And what could we do about that? So there are any number of strategies that we can use this non-invasive tool to really get at that. So we can calculate connectivity in any network in the brain from any location to any other location, understand how it's changing over time in children to get at these answers. And so I would be honored to help you all with that and really just kind of put that out to the broader audience out there to form a consortium in which we collect resting state functional MRI on all children with hypothalamic hamartoma to get a handle on this. Thank you. Questions? Do we have time?
We can take like one question.
Okay.
We've got to move on. And people also are welcome to approach.
Yeah, I'm here. Okay. Oh, go ahead. Yeah.
My daughter has been treated in Texas Children's, and since the first time she had this functional MRI as a protocol. I don't know if these things that you are doing now are applied by them, or is this a new thing?
I was at Texas Children's for my entire residency from 2007 until May of this last year, and then I moved to Phoenix Children's. So all resting state functional MRI analysis was performed personally by myself at Texas Children's Hospital. And currently, there is no one there, I'm told by Dr. Curry, who is analyzing any resting state functional MRI, although they're all collecting the data still, thankfully, but there's no one there to analyze it. So I'm at Phoenix Children's Hospital and happy to help if you would like to have a resting state done.
Because we have only the lists from these MRIs, should that be enough? Have some information?
Yeah. So the data from the resting state is yours as the family. You own your medical data, and you can do with it what you like. Is that what you're asking?
Yeah, but what would be the benefits of analysis?
Ah.
Because I have always asked in Mexico, for example, what does the MRI, functional MRI, is for?
Right. So what we're using it for here is to understand, first of all, is your child a surgical candidate? Do we have information from that resting state to be able to direct where we should lesion the HH to stop your child's seizures? And furthermore, what I'm proposing is like on a larger scale and yet unproven, and can it be used for understanding the neuropsychiatric and cognitive differences in the children and what interventions might or might not work in your child?
Okay, so could it be rewarded to do this type of analysis with this new software that you have developed?
Yes.
The MRI?
Uh-huh,
Okay,
right.
then we could contact to the Phoenix
Yes.
Hospital
Yeah, well, I'm not saying I know it would help for neuropsychiatric. I'm just saying I'm proposing that that is a direction that we could take it in. Most of the resting state studies out there are for neuropsychiatric disorders. Very few are for epilepsy, and these are probably the only ones that are actually for intervention.